One of the reasons I became interested in the nail is because it offers a different facet than any other fixation device offers. And that is the possibility of actually performing some of the correction after the operation rather than during or before it. As osteotomy surgeons, we're all very concerned and very specific about gaining accuracy, and that can be gained both before the operation and during the operation using conventional techniques, but never before have we had the opportunity to actually do something post-operatively. And what this is now offering us is not just accuracy, but a type of accuracy we've never seen before. And so it offered that, and the early experience is that it is indeed delivering just that, which is really exciting. Well, we fix the nail within the patient's tibia with screws, and we fix it in the uncorrected position, having made an osteotomy in the conventional way. And the nail has a very clever device which involves use of magnets within the nail and a magnet outside of the nail, which is contained in something called the ERC, the external remote control. And this external remote control is used by the patient at home to actually deliver a message to the magnet inside the nail, which causes rotation of components within the nail, which actually distracts the nail. There are two pieces to the nail, one of which telescopes out of the other, and each is individually fixed with screws to the tibia, and as the nail telescopes, the tibia distracts. And if it's designed as cleverly as it is, that means it distracts in exactly the right direction to actually move the osteotomy in the desired position. So we can actually do this on a dosed basis. Patients do it 1 or 2 times per day, very small amounts of correction on several days according to your specified correction, which is calculated very accurately. But the real benefit is that when things don't go quite as predicted, if human error comes into play, as it always will, then you can readjust and you can make a second estimate or a third estimate or a fourth estimate, and we can even correct these legs out to 6 weeks when patients come back to clinic. So we can really nail it, if you like, the accuracy. The actual osteotomy is exactly the same. The cuts that we use, and we use what's called the biplanar cut traditionally in our recent experience, conventionally, shall we say. There is a learning curve like there is in everything, and it's not just the learning curve for the surgeon. There's a lot of training and a lot of encouragement to use with your staff who've never seen anything like this before, because there are elements which are different in that you have people in theatre who are helping with the device in terms of the delivery of the magnet post-operatively. So this has to be explained to the staff, and you have to engage people in this process. However, the surgery itself is not desperately complicated, and a lot of it is just about performing an osteotomy well and putting a nail in, and those two individual procedures are very, very run-of-the-mill and routine these days. But what's really interesting is that, and it's something about osteotomy, surgeons get quite excited about it, but the population we operate on tends to be a very engaged and interested population. So it's been absolutely no challenge whatsoever to engage these patients in this process, and they're actually quite excited about it. And some of them even said, "I'm honoured to be part of something new," which is fantastic. So there's been no issue whatsoever in getting patients to want to do it and want to join in, and that's, as you know, in life is half the battle in any new change you might introduce. The actual mechanics for the patient of lengthening their osteotomy nail is really simple, and we get a lot of support from the company in the UK, and they're very good. They've even been to patients' houses in the wilds of the Lake District to help on some occasions, so there's been no issue with that whatsoever. So as long as we give the good pump priming of the patients with good information before, good discussion, good user group meetings, which we've had, and then supported afterwards with good industry support, then no problem whatsoever, and patients have been absolutely delighted with the service they've had. We've done a lot of work on accuracy because it is one of those things that concerns me. If possible, we need to be able to say that being accurate is better than not being accurate. At the moment, we're not in a very strong position to say that, whilst we know that the extremes of accuracy, of undercorrection or overcorrection, will almost undoubtedly give you a bad result. We don't know if the middle ground corrections actually make much difference if they're accurate or not. So I would like to establish, if possible, a relationship between accuracy and outcome. And the early results are fantastic in terms of the achieved outcome, in that the first 5 that we performed at 6 weeks showed an accuracy of within 2% of the desired Michelet's point, which is if you like, a percentile of the width of the tibia divided into 100%, and we normally aim for something like 55% when we're correcting, and so every one of these was within 2% of the 55%. Now, if we plotted that on a graph of the last 100 cases which I performed, and we retrospectively looked at all of these corrections, it comfortably fitted within the top 10% of all of those 100 corrections, quite comfortably beat more than 90. So it's a very, very accurate procedure. And as so far, the other thing which has really excited me is the speed at which the osteotomy gap appears to fill in with new bone. And we're performing another study looking at CT scans of the early healing phases of these nails and comparing them with the early healing phases in the standard Tomofix osteotomy. There's a fantastic course which started off in Basingstoke, which followed from enthusiasts in Basingstoke taking the lead from Holland, where some expert surgeons were working in Nijmegen, Ronald van Heerwaarden. So we've relied upon European inspiration and teaching and expertise, and we're now developing our own footprint in the UK, which is giving us our own excitement and our own journey which we're on to try and develop osteotomy and do some things which are different. So yes, this concept and this device will be discussed at the next course, and we'll be using this as a potential deliverer of the accuracy, which makes some people rather scornful of osteotomy, in that it seems like a very inaccurate, very sort of ad hoc, less scientific intervention, whereby if we can show that this is perhaps what we would do with one leg, put it to 55, and with this leg we might put it to 58, and actually be able to deliver that rather than just say it beforehand, then that might make people look very closely at what we're suggesting, because I have no doubt whatsoever that the journey, so we talk about the pendulum swinging, it's going to swing away from knee replacements going forwards and back to the basic principles of alignment and articular cartilage. Not at all, and one of the big misses, I think, and one of the reasons it's so easy to put a knee replacement in now, is that the surgeons who are doing it won't be there for the huge tidal wave of problems that it will bring in the next 20, 30, 40 years. If you're 50 now as a male and otherwise healthy, there's a 17% chance you'll make it to 100. And if you're 60 and 70 and healthy, then that probability grows. And we also know that if you're having a total knee replacement before the age of 58, then you're more than evens to have it done again. So if you're doing a knee replacement in a young person, not only are you perhaps limiting their function, but you're almost definitely consigning them to further quite serious surgery in the future, which may go wrong. I think really all of the things that we do a normal osteotomy for, and that's partly because we're introducing new technology to be on the safe side, but I suspect going forwards that this may offer a fantastic accuracy where we're in the field of complex surgery, perhaps when we're doing double osteotomies, when we have so many variables going on at the time of surgery that there may be adverse outcome due to fairly fine, minuscule error, in that we can actually deliver post-operative accuracy, having performed major surgery, and complement the intricacies and the expertise which is performed at the time of surgery with this extra component of accuracy thereafter. So it may have some really useful functions which we haven't yet tapped into, but we have to establish the initial safety aspect and and get used to the way it works and the predictability and maybe problems that might be associated with it first.